Hello, everyone, and welcome to today's event. My name is Sheila Ager, and I am Dean of the Faculty of Arts. Before we move along, I'd like to begin by reading our Territorial Acknowledgement. We acknowledge that we live and work on the traditional territory of the neutral, Anishinaabe, and Haudenosaunee peoples. The University of Waterloo is situated on the Haldimand Tract, the land promised to the Six Nations, that includes 6 miles on each side of the Grand River. Land acknowledgements are a historically accurate way to recognize the traditional Indigenous territories of a place. We believe it's important to honor the past as a small stepping stone towards reconciliation. If you'd like to learn more about what steps the University of Waterloo is taking toward the Truth and Reconciliation Commission's calls to action, please visit our Indigenous Initiatives pages on our Human Rights, Equity, and Inclusion website. So let me say welcome again to this inaugural event in a 4-part series that's going to be focusing on the human being, both at and as the center of today's most pressing issues. I am really pleased to have you all participating virtually today. I think all of us have adapted to these new platforms for communication in ways we never thought we would. And we've even been able to take advantage of them, I think. For instance, we're able to have an audience of hundreds today that we probably wouldn't have been able to do live. And not to mention, more importantly, perhaps, it means I can be here in my bedroom slippers. So these are strange times, and questions around health are more urgent than ever. And it's never been more clear that building a sense of community is important for all of us to feel connected and to thrive in these challenging times. I want to say that you folks, our alumni, are absolutely vital to our community. And we thank you for joining us today as we try new ways to engage with you and to help you engage with each other as well. So while we'd really love to see your faces in person, we do hope that today's panel discussion will still be memorable and enjoyable for you. You will have an opportunity to share your feedback with us by way of a survey shortly after the event ends. So please, please, please share your thoughts and your insights and your ideas with us so that we can continue to adapt and find the best ways to strengthen our Waterloo alumni community. And speaking of sharing, I'd like to take this opportunity to share with all of you the excellent news just announced this week that Dr. Vivek Goel, who's well known for his work in health policy and health research, will be joining us as of July next year as the new president of UW. And today, we are privileged to have with us our current president and vice chancellor, Dr. Feridun Hamdallapur, who will be providing us with a final word at the end of the event. And I see Feridun there, if you'd like to give us a wave. Thank you. Now, before we get started, just a couple of housekeeping notes. First of all, you will see the chat panel on the right side of your screen. If you would like to pose a question to any of our panelists, please put it there. Also, very important, our panelists will be staying on past the 2 p.m. mark in order to respond to as many of your questions as possible. Okay, today's discussion. Well, human minds and human behavior are at the center of our healthcare challenges and our successes. So today we're delighted to have our panelists here to discuss how history, economics, demographics, and politics have impacted healthcare in Canada. To moderate this panel, I am honored to introduce our moderator, Stacey Daub. Stacey is currently Vice President of Strategy, Integration, and Digital Health at North York General Hospital in Toronto. And she'll be joining Quinte Healthcare this coming January as their new president and CEO. Congratulations. Stacey's healthcare leadership experience spans 2 decades, and I want to pass the reins over to her now so that we can jump right into the discussion. So welcome, Stacey, and it's nice to see you again.
Thanks so much, Sheila, and good afternoon, and welcome to all my fellow University of Waterloo alumni from across the world. I can't believe how many people are participating today, and I think it's fantastic. Many of you have reached out to me before the session and are really excited about it. So I'm really intrigued and excited about being able to join you today, as well as our panel, to talk about the current pandemic through the lens of history, economics, and politics. So to get started, I'd like to tell you a little bit about our panel speakers to provide the context for our conversation, and then we're going to get into the discussion. Emma Parar is an associate professor and associate chair of undergraduate studies in the Department of Economics at the University of Waterloo. Emma is also currently a fellow of the Rimini Center for Economic Analysis. Her research interests are focused on health economics and applied econometrics. Tongue twister. Nell Wyman is Canada's first female Indigenous psychiatrist and is currently the Senior Chief Medical Officer at the BC First Nations Health Authority, another first in Canada. She has a long history, an amazing history of providing support to people and communities across Canada, as well as having many notable posts with government, public health, and academic organizations. Heather Mcdougall is a medical historian who researches Canadian health policy, public health, vaccine history, and hesitancy. Heather has had many academic posts at the University of Waterloo and continues to contribute at the local, provincial, and federal level in the interests of history of medicine. So Heather, let's start with you. This isn't humankind's first run at a pandemic. What can we learn from the world and Canada's prior experience with pandemics? What is the same? What's different? What key lessons from the past can we use to inform our generation's pandemic and its impacts on our citizens and country?
Stacey, thank you so much for asking those really, really pertinent and crucial questions. When I look at the 1918 flu pandemic, I see some really striking similarities. It generated a certain amount of fear and panic throughout the country. But as we saw also with COVID starting in March, it also brought forth a great sense of community and all sorts of community cooperation. Community groups rallied in 1918 as part of the war effort. We were in the final 100 days of the war in the fall of 1918. And we saw the same kind of thing occurring, not in an organized official capacity, but through Facebook and multimedia, which is, of course, one of the great differences between 1918 and 2020. I think that the other significant similarity is that social determinants of health, poverty, ethnicity, employment status were as important in 1918 as they have turned out to be in 2020. And in 1918, many middle class and upper class people actually got involved in community work, and I think realized for the first time that change needed to happen. But as we know from history, it didn't happen at anything other than a glacial pace. And I'm thinking here of old age pensions, unemployment insurance, and ultimately Medicare. In 1918, the flu hit very, very quickly, more quickly than COVID has been hitting us. And it overwhelmed the existing health departments and hospitals. But they rallied and they took over hotels and did the kinds of things that are happening again in the 21st century. But it was fundamentally good nursing and hope of a vaccine that gave people, I think, hope. As we are seeing, the fundamental public health requirements of good hygiene, healthy diets, masking, physical distancing, they were at issue in 1918. And although the province of Alberta mandated masking, no other Canadian province, to my knowledge, did so. And there was a lot of feeling that it wasn't actually a solution because, of course, all the masks had to be handmade. And the longer you wore it, the wetter it got, the less pleasant it was to wear. And there was a real question of whether it stopped the disease from spreading. So the pro-mask and anti-mask groups of today are not new. Quarantine also was an issue, and we've had our experience of that with personal and family isolation. The fundamental differences, of course, in the Canadian context were that we did not have a federal Department of Health. The World Health Organization did not exist. And so people automatically turned to their city or provincial boards of health for advice and guidance. And in seeing the same devolution of authority and the same focus on local action in 2020. So although that's a huge difference in that the federal government exists and the public health agency, and they are doing their best to create a national sense, in fundamental terms, dealing with this disease comes down to the local level and to all of us as families and individuals. In 1918, the internet did not exist. And so the speed with which misinformation travels around the world today was not quite the same kind of factor. But when I look at the newspaper coverage of the day, what I see is remarkably similar to the present, in the sense that you have the official line on hand washing, staying home when sick, and generally relying on expert guidance, versus the consistent closure of businesses and social gatherings of all sorts. And then you have the ads for patent medicines, CCM bicycles to stay in the fresh air and avoid having to be on the public transit. So really what we're seeing via the internet is the same kind of home health remedy as was suggested in the early 20th century. At least we're not being told to wear rings of garlic around our necks as a preventive of the disease. But the same types of misinformation, miscommunication, and questioning of science seem to be happening in 2020 as were to obvious in 1918. But perhaps the biggest difference is that, of course, in the fall of 1918, most of Canada experienced the epidemic of that particular period over the course of the span of months from basically August, September through to November. I think that 21st century people are having a hard time because COVID has seemed so very, very long. But what we have to remember is that Canada in 1918 had a population of 8 million people. 50,000 people, most of whom were somewhere between 20 and 45, are listed in the official death tallies, which actually are probably should be far higher than they were. So we lost an entire generation of men, young men and women in their prime productive and family formation years. And the consequences of that were very, very long lasting because it left a lot of orphans and a lot of senior citizens who didn't really have any social supports to look after them. So in 2020, we have done a better job, but of course, COVID appears, at least first wave in the spring, to have attacked predominantly people in the 60 to 85, 95 age bracket, whereas now that we're into another phase of it, it would appear to be predominating in the younger age bracket in a somewhat eerie and uncanny parallel to 1918. So when you think then of the lessons that needed to be learned, first and fundamental one is that community action is essential to protect everyone. And at the beginning of COVID, Canadians certainly rallied to that, and to a large extent, they are still strongly supportive of that. Patience and resilience. In the fall of 1918, Canada had been at war for 4 long and incredibly grueling years. And in some ways, the disease was just one more disaster on top of all the pain and suffering that had taken place up to that point. But because they had been facing this, the Red Cross, the volunteer groups could shift their focus from predominantly the war effort to the domestic effort. We were caught off guard by COVID-19. So it's taken basically to this point in time to get the volunteer groups functioning as effectively as they are today. The question of the vaccine. In 1918, no one knew that flu was a filterable virus. And so all the vaccines that were created were essentially useless. In 2020, we have seen truly an incredible worldwide scientific effort to develop a range of vaccines. And that is both amazing and encouraging. But it must not take away from the recognition that the social cost and price of this disease outbreak is far higher than the situation in some respects in 1918, because the population is bigger. It is much more obvious that we need to look for equitable ways to resolve this, and that it doesn't focus solely on health and healthcare and health policy. The social determinants of health, poverty, education, employment, and freedom from stress, are not exclusively within the domain of health. So in our post-pandemic world, and we will get there, there are huge policy issues that need to be grappled with.
Thanks, Heather, very much. There's something very comforting in listening to a historian talk about that people have come before us, have experienced many of the things that we're experiencing. I think for many people, and certainly in my generation, we have never had to face a public health issue of this magnitude, especially on a global basis. So Emma, I'm going to turn to you next. Emma, can you talk to us, given your areas of interest? I think it'd be really interesting to hear what's been top of mind of you. What have you been thinking about in terms of the relationship between the pandemic, the economy, and the health and well-being of Canadians?
Thanks very much for the question. What I have found most interesting of this recession is how different it is from other recessions in the past. So before the March lockdown, before the pandemic hit, in January, everything was going well. The unemployment rate was stable at 5.5%. The real gross domestic product, which is basically how much Canada is producing, was growing at a rate of 1.6%. It was a little bit down from 2018. It was 2% in 2018, but it wasn't a big difference. Labor force participation, which is a proportion of individuals who are 15 years old and older, therefore who are of working age, who participate in the labor market, that was also stable at around 65%. It was a little bit higher for men than for women, but that's normal. It was 70% for men, 61% for females. And then the March lockdown happened. The effects were immediate and staggering. GDP in April compared to April of the previous year fell by 17%. That's huge. The unemployment rate climbed up to 13.9%. That's also very large. I mean, if you want to compare this to the 2009 unemployment rate, which was the last financial crisis, the last recession, in 2009, it only went up to 8.7%. So we're talking about a difference of 5 percentage points. That's very large as well. Labor force participation also fell. So although we're seeing the unemployment rate rising, the number of individuals who want to be part of the labor market is also contracting because people know that there are no jobs. And now in September and October, schools have reopened. We're somewhat back to normal. The labor market has bounced back, but the recovery is still very fragile because compared to a normal recession, what usually happens is that the first sectors that are hit, mostly employment. So for example, manufacturing, sometimes construction are the first sectors that are hit. This time around, it was retail and services. And those are services that mainly employ women. So in a normal recession, the men lose their employment, and then in the household, the females go out and get a job, any job, just to contribute to the finances of the household. The jobs those females would have gone to normally didn't exist because we had lockdown. So it's what happened in April and May was very different than what we're used to. In the long run, what could happen is that those women that had to opt out of the labor market, if they stay out of the labor market for too long, especially if we have a second wave, especially if schools close again, is that they're not going to be able to re-enter the labor market at the level of jobs that they had when they left. So we're looking at women being less happy at work, having a less career advancement, potentially having lower wages over their entire lifetime. They'll never be able to make up the difference. And as well, it's going to have a long-term impact on the finances of the family. And as a health economist, one of the things that I study is how income has an impact on health outcomes of people. And it's been shown in multiple studies across the world that the higher the financial resources of a household, usually the better the health outcomes are in that household. So if we're looking at having households who are going to be made worse off by the pandemic in the long term in terms of financial outcomes, we're also looking at worse health outcomes down the road. What research has also shown is that surprisingly, when the economy contracts, avoidable death also go down. So when the economy doesn't do well, motor vehicle accidents, deaths that are related to, for example, stroke and heart attacks, which are more related to stress level, they go down. And that's because people don't have to work overtime as much. They don't have to rush to work and get in a car accident on the way there, for example. But conversely, deaths that are related to mental health go up. So for example, suicides in recessions go up. So what could happen is that in the long run, we're going to see more mental health outcomes that are negative than we would have if there hadn't been such a contraction due to the pandemic. The news is not all bad. In Canada, we have a very good social safety net. We have a lot of programs to help unemployed people. This spring, when the pandemic happened, the federal government invested $214 billion in different direct aid programs. So for example, CRB, wage subsidy programs. That number also includes resources, additional resources in the healthcare sector due to the pandemic. And that represents 14% of our GDP. It's also very large. Many generations will pay for this in the long run, but it's worth it. It's a short-term cost that will lead to long-term benefits.
Thanks very much, Emma. Again, looking at the pandemic through the lens of economics and how distinctly this particular pandemic, I think, both in terms of its longevity, but also its pervasiveness against, across Canada, across income groups, across different Canadians, really gives a lot of food for thought. And I think one of the things that was interesting to me in the pre-sessions is your discussion about that we're just starting to understand. We can take history and what we know about economics to apply it, but we're not anywhere near understanding the impact on all of these things, and it really will be in the future that we'll be able to. So it's great that you're already thinking about those and trying to shape ways of looking at them and hopefully mitigating their impact. So next I'm going to come to Nell, and I do understand that I have given Nell the wrong title, so I'm going to clarify that Nell's working title right now is the Deputy Chief Medical Officer at the First Nations Health Authority in BC. My apologies for that. Nell, you bring such an amazing, diverse, and unique perspective, given both your background, the roles and experiences you've had, both in BC, but right across Canada and across such a vast variety of clinical, academic, public health. It's really quite astonishing, the experience that you've had. So hoping that you can share with the panel, given all of these different roles and past experiences, can you share how you think history and politics has shaped the pandemic response and support, really specifically for the First Nations community?
Thank you, Stacey. No worries. Bonjour, Ani. So my name is Nell Wyman, and I'm originally from Little Grand Rapids First Nation in Manitoba. And before I start my comments, I just want to acknowledge that I am Indigenous, not on my ancestral territory, but that I have the privilege of living, working, and playing on the traditional, unceded, and continuously occupied territory of the Coast Salish Nation, the Musqueam, the Squamish, and the Tsleil-Waututh. So, Stacey, some of the, sort of the comments and questions that you posed and that I've heard from my fellow panelists, when we think about how the pandemic, the COVID-19 pandemic, has affected First Nations, and I can really only speak at this point mainly from the context of British Columbia, where I am located. There is a lot of historical experience that Heather alluded to, but specifically for First Nations people, there is a lot of, there was, when the COVID pandemic first started, a lot of fear and apprehension around what was going to happen because of the history of Indigenous people, First Nations people being absolutely, decimated by infectious disease, epidemics and pandemics in the past. And not so much, not only including the remote past, but even experiences in the recent past, such as the federal response to the 2009 H1N1 outbreak, specifically in Manitoba, where communities in crisis were sent body bags as a response to the outbreak in those communities. So happily, I can say that I think even before COVID-19 hit, that there was a lot more work on partnerships between local health systems that served Indigenous people and provincial and territorial and federal partners, for example, so that there was, some degree of pandemic planning or community pandemic plans in place prior to COVID-19, even sort of, when it hit, even before it hit. But one of the challenges, of course, is here in British Columbia, for example, we have two officially declared public health emergencies going on concurrently. So in April of 2016, the opioid crisis was declared a public health emergency. And of course, earlier this year, the COVID-19 pandemic was as well. And the third major issue that we also consider a public health emergency, although it's not declared as such, is anti-Indigenous racism in the healthcare system. And we have a provincial inquiry going on right now where the preliminary results will be shared by the lead of that commission, Mary Ellen Chappelle-Lafond, within a month or so. So we look forward to that. So what we're really seeing sort of on the ground in our communities is a really, we're calling it an unintended consequence of the pandemic, that some of the public measures that necessarily have had to be put into place have had a really adverse effect on the opioid crisis, for example. So many harm reduction services were reduced or not available at all, including supplies. Some treatment facilities, for example, were completely shut down, and there's been a shift to delivering virtual services, as there has been for many other places. But unfortunately, we are in a situation right now where in British Columbia, for example, we have had more deaths during the time of the pandemic due to the opioid crisis than we have actually deaths related to COVID-19. And then, you know, there's all kinds of issues with the anti-racism piece about people actually feeling comfortable or safe to come forward for testing, for example. So there have been a whole number of changes that we've had, challenges that we've had to contend with. And for our communities especially, you know, one of the populations that is most at risk of severe outcomes of COVID is the older or elderly population. And, you know, our elders and our knowledge and language keepers are, you know, probably our most valued human and cultural resource. So we have done at First Nations Health Authority with the team and other teams that I work with here at the Health Authority, have done a lot of messaging, not just on the sort of, you know, the general reinforcing the public health measures that have had to be put into place, but providing culturally safe messaging for our communities to encourage them to adhere to the public health measures, but also to find ways to keep our elders safe, for example, and also find ways to participate in culture and ceremony that is so very important to many people. And we also have, I think, tapped into Indigenous resilience. You know, one of the overarching message, you know, that we have for ourselves really is that, you know, we are still here. We're resilient people. And the team that I work with developed something called the Good Medicine Initiative, which has received a fair bit of attention, not just provincially, but some national and international attention, where we have focused specifically on uplifting Indigenous stories of Indigenous resilience during the pandemic. And we have also used, in some cases, our very strong coping mechanism that is our sense of humor, because not everything can be, you know, this whole pandemic and has been quite heavy, as Emma mentioned, for people, and the mental health and wellness impacts, of course, we're experiencing, and we will, you know, we will continue to see as we continue on until a vaccine becomes widely available and we can be together again. But that's, I guess, what I want to leave people with is that, you know, ultimately it's a message of hope that I think is relevant for all Canadians, not just First Nations, that, you know, we truly are in this together. And the more that we can work together to try to turn things around right now and get the case numbers down, the better off we'll be. And I'll just say one last thing, because I know we'll have a lot of questions, but I just want to say how very valued the time I had at the University of Waterloo. I had amazing faculty that I worked with, some of whom that I have had contact with over the years. And it makes for a very interesting story, Stacey, like you said, to have a background in kinesiology and biomechanics and yet be trained as a psychiatrist. So just here to say to all the attendees that no journey is ever wasted. So thank you.
Thanks a lot for that, Nell. It's actually funny. Similarly, my background at University of Waterloo could never have prepared me, I thought at the time, or I could have imagined the roles I've been in. So don't underestimate a University of Waterloo academic experience, because certainly from the panel that you're hearing today and the faculty, you never know where it will take you. So thanks a lot for that. So I'm going to watch the questions that are coming in, and I would encourage people, you're more than welcome to add some questions. I'm going to start off by one, and maybe on the topic of hope and optimism. So we have heard really, really promising news about the availability of a vaccine, and probably a historical record in terms of getting a vaccine through testing and actually ready for deployment. Heather, can you talk to us really briefly about what you think the ideal conditions are to see that the vaccine could have the biggest impact, and perhaps a little bit about, you mentioned earlier about this idea that vaccine hesitancy and some of these things we've experienced before. So what are the lessons learned from history that are going to optimize the impact of the vaccine in Canada?
Thank you, Stacey. Very pertinent and relevant questions. Basically, I think the major lesson learned from history was SARS in 2003 triggered off, yes, a search for a vaccine, and that search failed. There were three Canadian attempts, Chinese attempt, and that was why it was so very, very important at the beginning of the search for the vaccine in 2020 that public health leaders like Doctors Tam and New tried to damp down public expectations, because history didn't seem to be suggesting anything particularly positive. But of course, vaccine technology has altered since 2003 and certainly since 1918. It is far safer. There are very, very stringent requirements for, first of all, animal and then human testing. And there's a definite separation between the corporations and university researchers who are in fact researching to produce the vaccines and run the trials, and the scientific assessment committees that oversee the development of the vaccine and the trials. And so the announcements from Pfizer and Moderna are now being followed up with the presentation of the actual documentation of the trials to the Food and Drug Agency in the United States and to Health Canada here. And that is absolutely essential. And they are just actually the first two. There are other vaccine candidates out there. But vaccine hesitancy, I was struck by the fact that in the spring, when newspaper surveys were being done, media surveys, I should say, asking Canadians about their opinion, of course, one of the first things that they said was, oh, you know, we want a vaccine, we will all line up. So over the course of the summer, however, when things seemed to ease, support for vaccines went down, and that provided the anti-vax movement with an opportunity to spread their misinformation and to trigger off in a lot of people concern that it was rushed, that it wasn't necessarily going to be safe, and that traditional complaint that it was simply a money-making opportunity for the pharmaceutical companies. What kind of got lost in the shuffle, however, was that this is a worldwide pandemic. And fine, so, you know, North Americans get shots. We still won't be able to travel because the disease is pervasive elsewhere. And when we look at the global south, we certainly do need to ensure that they have access first, because they've got way less in the way of hospitals and healthcare professionals than we do to counteract the effects of the disease. So vaccine hesitancy, I discovered, is a very fickle thing because, of course, a survey done last week after the Pfizer announcement has increased the number of Canadians willing to get the shot. Willingness is fine. The logistics of the development and distribution of this are going to be a huge task, something you'll be facing in your there's no way that all 38 million of us are going to get the shot at the same time. And so the National Advisory Committee on Immunization has established guidelines that the provinces now have, but I suspect that we'll see the provinces opt for different approaches and identify different priority groups. And so the upshot of all this is, don't stop with the public health activities. Keep washing your hands, keep isolating, and understand that have to be made. We can't all be first in line, And this is where we have to think about the vulnerable people in our population and put them first.
Thank you, Heather. And just tying together a few comments around vulnerability and perhaps a comment that's been made in the chat. So it is true that the older population has been disproportionately impacted in terms of morbidity and mortality related to the pandemic. And I think it's fair to say that if you look at the national guidelines, they are really focusing their efforts on those and other populations that are most at risk and vulnerable. I see a comment here about the fact that there doesn't appear to be any prioritization for the flu vaccine for an older adult. And while there are, I think what that comment speaks to as an individual anecdote or an individual experience of someone, one of our attendees, it goes to show you exactly what Heather's talking about, that the logistics, the ability to take public health policies, whether it's prioritization, and operationalize them right down at the individual at the individual level is variable and a bit clunky, quite honestly, across Canada, and I'm sure very frustrating for many people. So just trying to tie together a couple of the comments. Another comment that we have received from an attendee relates to the impact. So kind of back to this point, Emma, that unintended impact consequences of COVID and our focus on COVID and COVID management. Nell made reference to the fact that it's had an incredible impact on harm reduction in the opioid epidemic. But Emma, can you talk to some of the other early thoughts health economists and actually public policy and others are thinking about in terms of the healthcare and as well as population health and the unintended consequences of focusing on COVID and this pandemic, perhaps at the risk of having other things get left behind?
Thank you for that question. It's true that it's a little bit of an approach of all hands on deck with respect to COVID, and there are some procedures that are elective that are getting postponed. Some cancer screenings are being postponed. It's also true that some patients, when they have to make the decision of whether to go to emerge because they have signs of a heart attack, they are hesitant about going because they know that there may be COVID patients in the wait room when they get there, and they're afraid of catching the virus. So it comes from a system management on one hand, but also from patients deciding to postpone getting healthcare because of the potential for catching COVID. It's much too early to know what the consequences of that will be. My sense is that there will probably be secondary death that will be due to COVID because we're postponing that healthcare. But at the same time, it's at the peak of the pandemic, it's necessary to try to control the transmission of the virus and to try to take care of those patients who have COVID and need an ICU or ventilator.
Mm-hmm. Okay, thank you. And I just see a couple of comments happening on the side related to the use of the term vulnerable. And Nell, I think, providing a good alternative around at-risk populations. So thanks for that, Nell. I want to, just as we talk about the health and maybe thinking a little bit about Heather's comments around the importance of individual actions. So there's government policies and individual actions and kind of the consequences and unintended consequences for individual. I can speak to recently working in a large hospital in Toronto. It is so interconnected. So when cases are down, it is within the hospital, we were able to ramp up surgeries, make sure that we were able to have access. But as soon as we started to take some of the control measures or people individually or jurisdictions, we started to see community transmission rise very, very rapidly. And recently we had an outbreak in our hospital, of which has happened at many, many hospitals. This is such a difficult virus to manage. And with asymptomatic people, it's inevitably going to come into healthcare institutions. And I think back to not the lists and the numbers, but the actual individuals who had to have their cancer surgeries canceled, or had to have a telephone call that they had just had a very life-saving operation and now had to be tested for COVID. So all of our interactions have such huge consequences, I think, for the way that we're managing that, and it really does get right down to the individual. Now, I think one thing that I think would be really interesting for the attendees to hear is that I do think that BC is really unique in the fact, on the basis that it really is so forward-thinking, and the experiencing of having a First Nations health authority, which I know is not universal. It hasn't happened across Canada, and I'm wondering if many of the attendees might wonder, what is the value of having a First Nations health authority, and putting in those types of structures that enable the First Nations community to be leading in the healthcare system in a very different and systemic and structural way. Can you comment briefly on that, and what your experience and why you think, your early experience and why you think it makes a difference?
Right. Thanks, Stacey. I will try to be brief. So for people who are attending, in British Columbia, we actually have 7 health authorities. We have 5 regional, a provincial health authority, and then First Nations Health Authority, which again is a provincial health authority. And our role is to serve BC First Nations in the province. And so I think, I've only been in BC for 3 years, so I in no way will take any credit for the long process that it took, various negotiating tables and the process that it took to set up our governance structure, for example. But essentially, we consider ourselves as working for BC First Nations and helping, supporting communities, I guess would be a better way, to achieve self-determination over, in this case, their health system. And one of the things we're noticing in COVID, for example, that's a little bit different from a Western medical perspective is, fostering not just the individual, that individuals will do well during the pandemic, but we think a lot more, I think, about the collective, as I mentioned before. And communities this time around, I would say, have really had their say in how they want to keep their communities safe. So, for example, there are supports and plans in place for communities that are isolated with very few medical services available to them, to be able to control access in and out of their communities. Haida Gwaii is an example that comes to mind, right? Everybody wants to go there because it's so beautiful, but because of the public health restrictions and the concern for community safety, there have been various points in times where, for example, access into and out of communities has necessarily had to be restricted. So we, our work in a variety of ways, now things have really been, we are on a level 3, we're considered a level 3 organizational kind of emergency. So 80% of our current work is on COVID right now. But, pre-pandemic, much of what we were focusing on is not so it's hard to explain in a very short answer, but not we are health focused, but not in that Western medical absence of disease model. We're very much focused on a health and wellness model that we think is going to be key to closing that gap in health status between First Nations people and the general Canadian population.
A model for other health authorities and ministries across the province to learn about. I do see that there are a number of questions, and one thing I've learned very quickly in the environment that I work in is I never answer infection control and disease questions because I don't have the background. And I think there are quite a few questions in here that are talking around, what's the evidence related to people with strong inflammatory responses and COVID. And I don't know whether, Nell, you might be the only person who might be in a position to make comment on any of these types of questions. Is that a question you might feel comfortable? It's that one around the inflammatory response. And the second one is around this whole idea of why there was so much hesitancy in admitting airborne transmission. And I would say that it's really droplet transmission, which and why wearing masks were not recommended right away. So from your public health background, and as you think about the pandemic, do you want to shed any light on those two questions?
I can do the best I can, but I guess the overall comment that I would say in answer to both questions is one of the key messages is that, you know, this is not called a novel coronavirus for any kind of arbitrary reason. This is a brand new virus that we have never seen or experienced before. So if people want to say have mistakes been made and call it that, sure, mistakes have been made. Errors in judgment or the timing of things could have been better. Like we will certainly, at least the health authority in British Columbia where I work, we're already doing some we're doing some evaluations on our response to date. But for example, the knowledge around whether or not people who get the cytokine storm, which I think is the inflammatory response, I think the evidence is still out on that one, that there are some studies that show that and some studies do not, and it will take a bit of time, I think, to have a definitive answer. And the same with the airborne transmission. I really want to dissuade people from having any kind of understanding that things are being kept from the public by public health officials. I think we're all trying to mire through this together. And initially, even for example, I've seen a lot of online comments critical of Dr. Theresa Tam around the masking recommendations. But initially, when there was discussions around masks, there was a big concern that there would be a shortage of PPE across the country. So it had a lot to do with procurement and being able to make sure that our frontline healthcare workers had everything that they needed to do their job safely. But there was also concern around ordinary people walking around wearing masks. I see it to this very day. People with masks underneath their noses, people with masks hanging off their ears, people touching their faces, readjusting their mask, touching their kids' faces. Like, part of the concern around recommending masks for everybody, and I don't mean to be humorous, but it's people just don't know how to wear masks properly in the sense, and especially the run on N95 masks was a little bit alarming, I think, at the beginning. So I think that decision was made with a big context in mind. It wasn't that the public health officials were withholding information. But certainly, yeah, in retrospect, could things have been done a little bit differently? I'm sure we'll all be engaged in that process as time goes by. But I think by and large, we have a wonderful example here in British Columbia, Dr. Bonnie Henry, who literally has worked day and night to make the difficult decisions to try to do no harm and try to make recommendations that benefit the most people, even though recognizing that in some cases it may be harmful to people, especially, I'm sure, as Emma could say, from an economic point of view. So thanks.
Thanks, Nell. I think that was very well said. Unfortunately, we're running out of time. We have time for one last question, so I'm going to pick one for one of our panelists who hasn't had really much of a chance to speak. Emma, the question posed, well, there's many that hopefully the group that's interested in economics and the pandemic can join in the after session, but the one I'm going to pose to you for the large group is this the time to think about the opportunity to introduce a minimum living income?
So full disclosure, I'm in favor of it. So I would say yes, but I'm biased. I I think at this point we have to think of financial aid to households as it's a need. It's not a luxury. We can't expect people to stay home when there's a lockdown and live on the money that they have been able to stash away. We can't expect that. And the pandemic is also affecting people who have lower incomes, lower attachment to the labor force. And those would be the people that basic income would help as well. So I think right now maybe it would be a good time. I have to say I was heartbroken when they stopped the experiment with a basic income in Hamilton. Hopefully they will try it. Thank you.
Thanks a lot, Emma. I think, if nothing else, I do think the pandemic has served to raise the issue again and to have it start circulating in terms of people thinking about the concept. And so that at least is perhaps another silver lining of the pandemic. I want to thank the panelists for being so great to respond to the questions and the variety of questions. I am going to pass it over to Sheila for some closing remarks.
Thanks so much, Stacy, and everybody. I want to come back to some of what you all had to say, but right now I know that our president, Dr. Mcdougall, wants to say a few words, so I'm going to invite him to go ahead. Faridun, please.
Thanks very much, Sheila. As I was listening to this fantastic discussion and conversation, I got curious. I said, I wonder what I was doing last year exactly on November 19th. So I went back and checked my calendar. There was nothing that I was doing a year ago had any resemblance to what I'm doing this year. The only common thing was I said, get your flu shot. So I got my flu shot for last year on November 19th. We were completely ill-prepared for what got thrown in front of us, this unbelievable challenge. And then if you study history, if you follow trajectory, we shouldn't have been that surprised. This was in the past, I don't know how many years, the third pandemic. And there's more to come, I'm afraid. And how are we preparing? So Sheila, first and foremost, let me thank you and the organizers for organizing this event today and making it in the form of a 4-webinar series. But they're all centered around humans and humanity. And I am so delighted that the word human is not coming as an attachment, is not coming as a secondary topic. It's not coming as this and humans, it's coming as the main heading, main topic, main issue. That everything has to be centered around that one. Whether it's technology, whether other things, it has to be human-centering, without which I think everything will be meaningless. And I was so delighted to hear some of the comments and discussions today that this is exactly what we're doing. This is a time where we need to understand much better what this is all about, regardless of how deep we go into science or technology or in any other areas. If we don't understand how it's connected to humans, why it's connected to humans, I think it will lose its meaning. In that regard, I'm so proud that our institution, and I heard some of the comments some of our speakers made, we made strong commitments to the excellence of what we do here, excellence of teaching and learning, excellence in scholarship and research. But we fell short of saying that we need to connect it to some very, very important key human elements. Again, I'm very proud that our institution made clear, unambiguous commitments to mental health, mental well-being in general. We made very clear commitments to who we are, what our history is, what our of the land we are situated on, and our Indigenous history, and our commitment to making sure that our institution is well connected to the findings of Truth and Reconciliation Committee. And finally, our understanding and our commitment to anti-racism, what this university should be the leading edge of what we can do, not just for today, but for generations to come, to establish a kind of environment that there will be no traces of Black. So again, I'm so glad that we had this event. I'm grateful for everybody who made a big effort in making today's event happen. I have the numbers of how many people attending today, and it's fantastic. On a beautiful afternoon like this, so many people, not just from here, but around the country, attending and participating in this discussion. So thank you so much for including me in this discussion, and look forward to the next 3 webinar series. Thank you, Sheila.
Thanks so much, Faridun. And many, many thanks again to our panelists, to Stacy and Nell and Heather and Emma. I think listening to you, it just underscored so much the incredible complexity of human society and the balancing act that it is to live as humans in a complex society. Heather talked about the flu epidemic in the wake of World War I, and as an ancient historian, I'm going to resist the temptation to speak about the Great Plague of Athens in 430 BC, because I know people are wanting to get back to the questions for our panelists. So just a couple of remarks before I say goodbye. I think today has been a wonderful example of how UW's alumni and faculty are addressing pressing societal issues and making an impact on the world. And I would like to give a shout out to our current students on this, because more and more what I'm seeing among our students today is that the way they're employing their co-op and their experiential opportunities, along with their academic studies, to address real problems, and they're bringing strong social consciences, what they do. And it really makes me hopeful for the future. So also many thanks to our audience for attending today and for contributing so richly to the discussion. Also want to thank our affinity partner, TD Insurance, Melosh Monex, for supporting this event, and letting you know that the next event in this series will focus on humans and work, and more specifically, diversity, representation, and inclusivity in our work environments. So be on the lookout for an invitation next January for that. So reminding you again that our panelists have kindly agreed to stay on past 2 o'clock in order to address the remaining questions. So please stay on the line, and I'll say once again, thank you, and we hope to see you again soon.
Stacy, if you'd like to continue looking at questions, we can address any further questions now.
Sure, I'm happy to do that. I was unclear about a little bit. So let me go back here, and I see that some people have signed off, but I will go back and scan a little bit to some of the questions. So one is around thinking about the post-pandemic world, and what advantages might we possibly see from the information research and awareness we've kind of obtained through this experience. Any of the panelists want to speak about that, or in terms of the silver lining? Heather.
Stacey, I think that the post-pandemic world, if we contrast it to 1918, one of the results of 1918 was the creation of a federal Department of Health.
Mm-hmm.
But the issue there was the definition of political power under the British North America Act. And that, of course, that legislation was simply flipped over into the Constitution Act of 1982. And so when people look at the situation I'm seeing this past couple of weeks, and for national leadership, it's time for Trudeau to put his foot down and tell the provinces exactly what to do. That is a total non-starter in the Canadian context. And the reason for it goes back actually to 1867 and to the way that each province has built up its own, in effect, healthcare system. The other aspect of all of this is that, as I said, it's time for people to stop thinking in such narrow, siloed terms. And the post-pandemic world is a huge opportunity, not just for a guaranteed annual income, basic income, but to rethink work, to rethink the way that women are just assumed to be the family caregivers under most circumstances. In other words, to question the way that society has unfolded up to the present, and of course, also the role of media in our lives. So that's why we have to get beyond healthcare, but never lose the human component.
So Heather, it's interesting you say that. Even in the healthcare world, I think we have had a disruption that is making us seriously consider how we deliver care going into the future, whether it's virtual care or other modalities. And I think one of the things is that will be important in the post-pandemic world to really understand what of these new disrupted patterns that we've emerged from the pandemic in terms of providing care, the way we carry on lives. How do we invest in research to continue to understand which modalities have good outcomes, good experiences for patients? And so there's a whole realm. I am going to go to an economic question now for Emma. And I have no idea about your background, and you're getting a very wide range, but this question relates to supply. And at the start of the pandemic, there was a temporary lumber shortage, and attendee indicated that they have heard that asphalt has also experienced shortages. Are these blips in supply or indicators of longer term trends in terms of resource availability?
It's really hard to predict that. I think it really depends on how severe the second wave is, because I think I'll admit we're going to get a second one. And also how many more waves there are and which sectors of the economy are most affected. I mean, another example of that were the meat packing plants, where a lot of workers ended up getting COVID. I think that the big advantage now is that we understand better how to control the virus, and we understand we have to socially distance. We have to mask, which wasn't completely clear at the very beginning of the first wave, but I think now everybody understands that. So I think that between those measures that are going to help mitigate the transmission of the virus, and hopefully being able to keep the supply chains going, I'm hoping these will end up being blips rather than long-term. And I'm convinced that once there's a vaccine, if there's no second new virus, we should be okay.
Okay, thank you very much. I see another question here. It's a bit of a more challenging one. So someone's asking about, and I think we have to view this in the historical context, about the use of NDA, so non-disclosure agreements. This is very topical on Ontario, of the fact that public health officers have been asked to sign non-disclosure agreements with the provincial government, and how that impacts the perspective of trust. Nell or Heather, do you want to give a shot at kind of sometimes how whether it's politics or how government works, and the interplay between that and what you read about, and how citizens experience that in terms of trust in the system?
Yeah, that's a big question. But I guess the most succinct way that I can answer that is to look at the different scenarios, not just across the country, but I guess internationally, how Canada, for example, as a whole is handling the pandemic compared to other countries. But here within the country, we have an example here in British Columbia, for example, and I'm sorry to keep going on about British Columbia, but that's my experience right now, is we have a government that places value on public health knowledge and officials to guide all of us in the province through this pandemic. And it's very, very important for public health officials to have that trust and credibility. And when, for example, public health messaging gets politicized, perhaps in Ontario, perhaps maybe a little to our neighbors to the south, but I don't want to be too controversial, that's where I think we start to get ourselves in a little bit of difficulty, because the part of it's a pandemic, so public health has to be a part of that. And part of what we do in public health is we rely, we can put public orders in place, but there is this element where we really need the public to engage with us, to trust us, and to follow through with behavior change. And the majority have. There's a minority have not, for various reasons. And one of the things that I've learned to kind of deal with is, initially when I was hearing of all these, maybe 3 or 4 weeks ago, there was a discussion here in BC about younger people not adhering to the public health measures and having parties. And at first, I'm a little bit older now, so I'm like, oh, those young people. But there are reasons I forgot about, the need to, at that age, to be connected, and how difficult it is when you add in the layer of how connected we actually are with social media and things like that. So we have to maintain that trust in public health. I mean, that's how you support people to make the right decisions for themselves, for the health of themselves and their family.
Now, I think that's a really good, I happen to live by the neighborhood of Trinity Bellwood that got North American shame over the behavior of young adults. And I think it's like anything, if you have an ounce of empathy and you can try and imagine the world through their eyes, and not use shame to change their behavior, but to try and seek to understand and perhaps get it in another way. So I think those are great comments. Emma, another question for you. What do you think will be the long-term effect of COVID for the insurance industry? On the general level, what kind of support could insurers, private and public, provide?
One of the questions I asked in my health economics class this year was whether the students thought that there would be a market for an insurance against the long COVID. So how some patients have symptoms and those symptoms aren't away after 6 or 8 months, and then, or I should say 6 or 8 weeks, and then they can't work. I personally think that there may be a market for that. I could see a demand for it. The question is, will insurer want to get in that market? And that I'm not convinced that they would be. Beyond that, because we have a public healthcare system in Canada, most of the consequences of COVID are carried by that public healthcare system. In the US, it's a different ballgame because there's a multitude of insured, there's a multitude of systems. So it's difficult for now to predict, but I could see it having an impact in the long run.
Okay, great. Next question is from Brian, and Brian is asking us, healthcare has historically been resistant to change, and I am the first one to agree with you on that, Brian. Particularly in primary care, I might not completely agree on that, where processes and the use of technology are slow, and as well as the uptake. Does anyone in the panel think COVID-19 might be the kick in terms of the adoptions of new technology and change in the primary care sector, and maybe on the, to just point out primary care, on the broader healthcare organizations, providers, and clinicians? Anyone want to comment on that? Maybe I could give a quick, so I can say I have had the experience of supporting kind of the rapid deployment of digital and virtual technology to support healthcare in the last number of months, and we have seen our visits go from, perhaps 2 to 3% virtual visits to 80, 90%, and they really were a reflection of necessity. And there were obviously economic imperatives. So it is a quintessential example of a burning platform that forced change. However, I would say that we need change leadership in terms of aligning incentives, looking for opportunities to invest in innovation. The average primary care practitioner or the average practice finds it very difficult to be able to bring new technology into their practices. So I hear you, and I've experienced it, and I am very intrigued about how we can get the right public health policy, organizational policies, and incentives and innovation to hardwire the gains we've made in terms of introducing technology. I think it's an opportunity that we cannot. We need to really look at how COVID has provided that opportunity. The family health team in my region right now moved to a virtual family health team and actually extended their support to any individuals who are having difficulty. And I think it really shattered a lot of the rules that people thought or that were in place. And now it really is a matter of trying to leverage those in public policy and organizational policy decisions and incentives.
Stacey.
Heather.
Stacey, I think what you've pointed out is absolutely right on the mark. And I think that in some ways, the vaccine rollout will probably be sort of the proof of the pudding, in the sense that there's been a lot of concern about tracking potential adverse effects from immunizations, but also, more importantly, tracking who exactly gets it, when they get it, and if we have to go, both of the leading candidates at the moment are 2 shots with different time spans between the first shot and the second shot. And so this is an opportunity in terms of immunization, which is a really fundamental component of preventive public health activity, to establish an online system that has barcodes on all vaccine vials, immediate inputting. The immunization of school pupils legislation in Ontario, when you have your child immunized, you are expected to phone the school and let them know. They in turn tell the local public health department, and my friends at Toronto Public Health tell me that they then have to physically input the data. This is nuts in the 21st century. And so this would be a really, really good candidate. I think the concerning thing about the primary care people is that a lot of them signed up with whoever sort of appeared in their office with an application package that they thought they could use. And so it'll be the same as computerization was when it went into doctors' offices. The province didn't mandate a specific supplier. There are too many different systems. And so, just on that level. But then going back to one of the earlier questions, the NDAs, privacy is a really, really, really big deal in Ontario. And there's this whole question of surveillance. And we have to surveil because that's how we tell where the hotspots are for disease outbreaks and where there are potentially vaccine issues. But we don't actually need individual names unless you're doing contact tracing. So I think that if we can come up with privacy regulations that would enable us to share our health information and feel secure that it wasn't going to be brought back directly to us, we'd have a much better sense of how the population is doing. But Nell is absolutely right. Trust and transparency are the hallmarks of successful public health. And you're absolutely right as well that you do not blame and shame, you educate, which takes us back to the 19th century and persuasion, not coercion.
Yeah. Now I'm going to pose the next question to you. And maybe it's a comment for you to respond back to. So Gary posted, I think young people behave the way they do in the face of the illness, of the COVID or the illness, is the probability of harm. Fewer than 1% of the population have been infected with COVID, and less than 2% die from it. So now, do you want to comment on that from a public health perspective?
Well, I think I think there are a whole number of reasons why young people, like all of us, behave the way we do. And the patterns of behavior that young people are showing is probably there are probably multiple reasons for it. I wouldn't attribute it solely to the fact that the probability of harm coming to them related to COVID is the only reason. But my sort of counter argument to that is it's not the broader issue is it's not necessarily just that harm will come to a specific young person or their risk of getting COVID or having a severe outcome. It's who they are in contact with. Young people get together in a group, say, of 10 or 20. They rent a limousine to party in. They each take their exposure to their own social and family group. The limo driver is exposed. They may take their exposure to their own family and community group, and so on and so on. So, we are not all kind of experiencing a pandemic right now with all of the public health measures in place and all of the adverse consequences just because this is an infectious disease that affects only very few. The issue is that it is a lethal virus. It is causing us to lose members of our community and our families who are very important to us. And we need to take it absolutely seriously.
Thanks. It's back to that, the conversation of humanity, right? And the value of a single human life. What I'm going to do is just a quick roundtable, quick fire between each of you around what you're most hopeful about in terms of looking into the next, into the future, kind of in the post-pandemic world. And why don't we start with you, Emma?
We've been able to get rates down before. I think that we will be able to do it again if it's needed. I think that we have to continue what we're doing. We have to continue to care for one another, and by that I mean stay apart. And also we need more government help as this will ebb and flow, hopefully get smaller as it goes by. And I hope that Canadians will feel comfortable and will take the vaccine when it is available.
Thanks. Heather, what are you most hopeful about?
I basically just want to second what you said. All history basically shows us and Sheila Ager's comment about the Great Plague of Athens. Yes, one of the first pandemics. And so given that, you know, we are all here as descendants of the people of the past, events like this do come to an end. No one can predict when this one will necessarily come to an end. But I think that my feeling is that what we really truly need to do is take the time, if there is yet another lockdown, to think about the world that we would like to see in future and to make it a better world than the one that we're currently in. There is too much racism, too much sexism, and all sorts, and poverty. And it's not just in Canada, it's everywhere around the. So on top of all this, we have climate change, which is undoubtedly at least a partial factor in the development of COVID-19. So we are at a potential turning point if collectively and individually we decide to opt for change. But let's take it in a positive direction.
Thank you, Heather. And Nell, I'm going to give you the last word.
Gosh.
What are you hopeful? Why are you hopeful?
Well, I guess first of all, I'd say that I'm hopeful because the only alternative is to be despairing. You know, I think one of the things that that I hear a lot about and that I experience is, you know, any type of collective crisis or adverse events, you know, does hopefully have a tendency to change our thinking a little bit, bring us a little bit more outside of ourselves and think more about the collective. And that really is kind of the First Nations perspective on things, right? Like I've had a lot of Facebook comments from friends about, you know, this is all about individual choice, but, you know, I'm so fortunate to work in a place and in a part of this country where our First Nations people teach me every single day that I am just one part of a connected system. And I think that's partly what COVID is teaching us, that we do, you know, that we are not in isolation, and we are in isolation, but we're not in social or spiritual isolation. And that we, you know, we will get through this, and we will hopefully, some of the innovations that people talked about, virtual ways, for example, of providing care, will hopefully continue, you know, once we are able to be together again physically. And on a personal note, I can tell you that, you know, I've had to kind of innovate how I interact with my friends. I mean, most of my friends are in Ontario because I moved to BC 3 years ago. And, you know, I've always said to them over the last 3 years, yeah, let's connect and keep in touch. But we really haven't in some ways. But now I have all these Zoom coffee chats with people that I get to see that I haven't seen in 2 years. So there's definite upsides. And I'm also looking forward to being able to travel again. I'm kind of a world traveler and a scuba diver, and we and public health, we have been working very long hours and very hard, and I can hardly wait to get into some warm water and swim around.
Okay, thank you. That's a great vision to end off, being in a beautiful place in not thinking about COVID for perhaps. So I want to thank the panel. I mean, one of the silver linings for me has been that opportunity to meet the panel and to have a couple of sessions with them. And, you know, it's been incredible to listen to where U of W alumni and academics, their perspectives, what they're working on. So that's been a great pleasure for me. I want to thank everyone for joining, and especially the 100 people or so who are still logged in after we finished at 2 o'clock for the post-session questions. So be safe and be good to one another, and thanks very much.